reparation must be made to allow healing for indigenous peoples and for Mother Earth herself. Thank you.
Thank you, Sean. And then we also have a slide to welcome our presenter, Nima Sheth, who's an MD and an MPH. And we put a little short bio here, but we also would invite the presenter to share anything else they think that the audience would like to know.
Thanks, Parker. Yeah, no, this is great. Everyone, thanks for having me here. I'm really excited to be here with you all. I would just add that I'm a psychiatrist by training with a public health background and have primarily worked with patients who have experienced trauma. So happy to be here.
Thank you. And then we also have another speaker, Ashley Lincoln. And if you would like to add anything, Ashley, you're invited to as well.
I don't have anything to add. I'm just really happy to be here and excited to be with you guys today.
Awesome, thank you. And you just give me a moment so I can swap slides on over to Nima so we can start the presentation. And is everyone seeing the correct slides?
I'm seeing them, Parker. Yes.
Okay. And they were okay. So then, yeah, take it away then and just let me know when you'd like me to forward your slides.
Okay, great. Yeah, I just wanted to spend a few minutes talking about some of the basics around stress, trauma, and resilience. I know that this is, as providers, you all, are can potentially experience, I'm sure are experiencing degrees of vicarious trauma, vicarious resilience, and kind of secondary stress. So we just wanted to touch on that a little bit. Next slide. So we kind of did this already, but just taking a moment to arrive. These are heavy topics, and it's really hard work that you're doing. So just wanted to kind of acknowledge that at the beginning. Next slide. So starting to talk a little bit about stress and the stress response. So even before we think about trauma, right, we just want to think about stress. So trauma is really a stress reaction. When we start to think about trauma, we think that, it's a little bit more pathological, but really it doesn't have to be at all. In fact, most people who experience some degree of stress and trauma, it's not pathological, meaning it's not, something abnormal like that is a health condition or a disorder per se. It's a normal reaction to something that isn't normal, right? And so I just want to be mindful to point out that, a lot of times we immediately pathologize stress reactions and trauma reactions, but they're just human reactions, really. So stress response is, an adaptive response to any environmental stimulus, right? That enhances survival, development, or function. So there's good stress too. We need stress to survive, right? It's not just an emergency response, but a responsive adaptation, really. So mild stress can be really beneficial and can improve performance, but then higher stress can impede performance, right? And then severe stress, of course, can be very toxic. Next slide. So just to say that we're all fragile and resilient in the sense that, and I'll explain what I'm talking about later, but, to say that any one of us can be in a situation where we're experiencing a degree of stress that can become toxic and, problematic. And we can kind of switch in and out of these different, the kind of spectrum of stress that we might experience. And I'll show you what I mean in the next couple of slides. Next slide. So there's 4 causes of stress injury, and I would add here the historical intergenerational trauma as well as a form of stress injury, which is not in this picture, but I would definitely add that in there. So there's, a life threat, which is what we think of in traditionally, when we think of things like PTSD, we think of a life threat, right? Some kind of traditional exposure to something, to an injury, something that's horrific or gruesome or death. And a loss injury, which is a grief injury. So, and often these two things go hand in hand. So when you've experienced any kind of trauma, you're usually grieving something, right? So it's either the grieving a loss of a part of yourself or grieving someone or something that you've lost during the traumatic event. And then inner conflict, so moral injury. And I think this is one that is really important for providers, because especially like during things like COVID or, other disasters, they're having to make decisions that might benefit some, but come at a cost to others. So it can be really, distressing. And we saw a lot of moral injury in frontline healthcare providers during COVID, for example. And then fatigue injury, which is probably something that everyone is experiencing at some point or another, just the accumulation of stress over time because of insufficient rest and recovery. And I think I would add that, intergenerational or historical trauma can also, which of course is really relevant in this context, can continue to contribute to all of these, right? So if you have that pre-existing intergenerational historical trauma, you can, when you experience any one of these, it kind of lowers the threshold to then have kind of a bigger stress reaction because of the cumulative traumas that you're experiencing. Next slide. So I really like this slide. I know it's a little busy, but it's really a good slide that talks about the stress continuum, right? And this is what I mean by we're all fragile and we're all resilient, because we can kind of slide in and out of these over our lifetime. So, many of us are in the yellow more often than not, and can easily get to injured, right, which is orange, which is when we get to the point of just too much going on, potentially having vicarious trauma from patients we might be seeing. And then, pretty quickly can lean over into red as well, where things become more kind of quote pathological, right, where you would want to you really want to get professional treatment, but then quickly slide back into orange and yellow, throughout the course of treatment or thereafter. So any of us can be, and we can slide in and out of these different columns. And these features in particular are talking about healthcare providers. This is a slide that the Schwartz Center, I think, put together during the COVID pandemic. Next slide. So these are the core areas impacted by trauma. And these stem out of cognitive processing therapy that is a great kind of evidence-based therapy for PTSD and trauma disorders, but they're really at the core of what trauma, what folks who have experienced trauma, tend to where they tend to manifest in their life. So feelings of helplessness, loss of control, difficulty with intimacy, whether that is friendships, your partner, mentors, just new relationships, self-esteem, safety and trust, both with yourself as well as with other people. And then just wanted to make another note here, the fact that historical and intergenerational trauma would, again, contribute to this, right? So if there's pre-existing trauma of that sort, it can kind of contribute to worsening some of these different areas that can be impacted by new traumas. Next slide. So now I just want to spend a quick minute talking about stress and trauma in providers. Next slide. These are some of the, and I won't read all of these are just some of the kind of symptoms, sources, and signs of stress that you might notice, particularly in providers, but of course also in patients. But I want to highlight a couple. So, competency and confidence level can really drop. And so if you start to feel like, okay, I don't feel equipped to do this, it might not be reality in that you're not equipped to do it, but just a feeling, because of how overwhelmed people can feel. Of course, guilt because of feeling like you always want to be doing more. I think that's a common one we see, and feeling like you can always do more to help your patients, which is also really, really hard. And then demoralization, like you're doing everything that you can, or again, moral injury, having to make decisions that, you don't really agree with. During the pandemic, for example, we saw, providers feeling like they had to be at the hospital to help their patients, but then they were exposing their family to COVID, every time they were going in. So that was an example of moral injury. Next slide. And so again, I know this is a busy one, but this is just another kind of focus in on moral injury because it's so particular to providers. And just the purple boxes are just talking about, what are all the things that contribute to moral injury, and then what are the results of moral injury? So once you've experienced moral injury, what kinds of things might you feel? Compassion fatigue may affect spirituality, feelings of powerless, not wanting to work, survivor guilt, things like that. Next slide. So now I just want to touch on, I know we're kind of jumping around, but just want to touch on resilience and vicarious trauma. So first to discuss resilience a little bit, so next slide. So resilience, what is that? So it's really the ability to bend but not break, right? So is it static? Is it dynamic? And these are kind of rhetorical questions to help us think about this, right? So this is from a study done in 2014 by Maston et al. It's capacity of a dynamic system to adapt successfully to disturbances that threaten the viability, function, or development of that system. So it's really, again, a process of adaptation, right? Which is not dissimilar to stress, actually. But it's the capacity of that system to adapt successfully, right? And so again, so it's a little bit more scientific definition, but I think when we're thinking about, the molecular end of things, this is kind of important to keep in mind that this is what resilience is. The next slide gets to, more of kind of outside of the molecules. Next slide. So what are the different factors that contribute to resilience or take away from resilience, right? So there's predisposing factors. These are kind of our biological factors, personality, environmental, social, cultural factors, what kind of support system we have, and then the different kind of characteristics of the stressor. So like, is it a stressor that we can control? Is it a chronic stressor? Is it a one-time stressor? And then the stress response, right? Which is it emotional, behavioral, biological, or cognitive? And then the aftermath. Do we have safe spaces to process that stressor? So our support systems, our spiritual systems, locations, and again, that contributes back to the predisposing factors. Next slide. So the last topic, I just want to move on to vicarious trauma. Next slide. So I wanted to cover a little bit around work-related trauma exposure and vicarious trauma. So there's definitely a spectrum of responses, and we know that vicarious traumatization can lead to a change in our worldview, right? Can make people more cynical. It could make people less spiritual. It could also have the opposite effect, make people more spiritual, make people more connected, depending on how we respond. So starting with the neutral response, is that, the neutral response technically is that you're managing that vicarious trauma effectively. I will say this is rare. People think that they're managing well, but they're really just suppressing a lot of times, right? And are not cognizant that they are actually experiencing a degree of vicarious trauma, and that it's contributing to their life. It may never get to the point where it doesn't contribute to their life much, and they're able to kind of adapt, and that's wonderful. But more often than not, we have the negative response, which is that we do experience vicarious trauma and secondary traumatic stress and compassion fatigue. And secondary traumatic stress is really experiencing secondary traumatic stress symptoms, right? Like nightmares, hypervigilance. We might ourselves feel like, if we're hearing a lot of stories of trauma, feel like the perpetrator in those stories because we're asking patients to discuss that. Because we're asking patients to even talk about it and work with them. You might experience, some of the same symptoms that your patients are experiencing. You might be hearing a lot of cases along the same line. So for instance, when I was in practice, I was hearing a lot of cases around sexual assault, and I felt like it was all around the same time. And I was starting to notice, some secondary trauma symptoms like distrust in males for no good reason, looking behind my back a lot, not walking alone in areas I would normally be comfortable walking alone in, just things like that. And then you could have a positive response. So vicarious resilience and vicarious transformation and compassion satisfaction. So those terms are all a little bit different. I won't get into the details, but vicarious resilience is essentially the ability to extract resilience from the work that we're doing and from the clients that we're seeing. Next slide. So these are just some of the symptoms that you might see in vicarious trauma. You might notice a degree of lability or numbness in yourself, difficulty sleeping, more headaches, stomach aches, things like that, irritability, conflict with those we love, and then like actual trauma symptoms, hypervigilance, avoidance, or destructive behaviors, feelings of isolation or apathy. And so it's really, really important that at this point, if that's being experienced, that we have ideally a community we can reach out to that usually includes peers, mentors, family, and professional help. Absolutely. Next slide. So I think that's it. I'll pass it back to you, Parker, unless anyone had questions or comments here.
Yeah, if anyone has any questions or comments, feel free to leave any comments in the chat right now, and we can read them and maybe you can get some answers.
Somebody did leave a question about what group of people walking on Earth have the highest level of signs and symptoms of PTSD. I don't know if we have data on that. I think we could just say by risk factor, so like folks who obviously have risk factors like living in more difficult conditions, including poverty, lower socioeconomic supports. Although oftentimes there's other support systems that go into place in areas of poverty, so it's hard to say that for sure. And I think it would be hard to study this because there's so many confounding factors to be able to really compare. But we know, for instance, in the US that we see high degrees of PTSD in forced migrants. So people coming at refugee status, seeking asylum. And, we know that there's higher levels of PTSD amongst certain populations like that. But I don't know if I have a definitive answer there. And then the question of what is meant by spirituality in this context. In the context of the presentation, I think that's meant to be really broad because everyone defines spirituality different to them. And so I think it's any form of, belief system that they have that keeps them sustained, right? It would be really broad in that sense. And we, as providers, we'd really be learning from our patients around what spirituality means to them. And from peers, we would be learning as well, right? From peers around like, what does it mean? That's one of the first questions to ask is, what does that mean to you? What does this belief system mean to you? How does it impact you? Okay, I see another question around ACEs affect resilience efforts. Yeah, that's a great question. Unfortunately, we know from the literature that ACEs do, to a degree, can impair, resilience because the earlier we're exposed to adverse, traumas. It can impact our ability to then cope with future traumas. But having said that, again, there's so many factors there. So it depends on if someone who's experienced ACEs, can they be in a setting where they're able to recover? Do they have enough support to recover? And then their ability to rebound kind of increases, right? So this is like a flexible threshold in terms of how we can respond. And the more insults we take, the more kind of injuries we take, the harder it becomes to rebound and respond. and it's like, if you remember that cycle with the resilience, it's all those kind of contributing factors, the biological, psychosocial, environmental. So it's hard to say like how much ACEs would affect resilience, but we know that it would. Yeah, that's a great point. Resilience doesn't seem to fit American Indians or Alaska Natives, as they haven't been able to bounce back to the original state. And that's a really good point. And I think resilience, the definition of resilience wouldn't necessarily mean to come back to your base state prior to the trauma occurring. It would be the degree of adaptation that you would see to the situation. Having said that, I mean, to be honest, there isn't the rights that these folks should have are not in place, and they're not being treated equally. And there's a lot of structural socioeconomic issues there that contribute to the trauma and ongoing trauma. So it's not, I don't want to say this is just a personalized thing. It's as a country, I don't think we've taken responsibility for this. And so I think that is going to continue and be a propagating factor for ongoing trauma and is going to affect resilience. Anything else? I hopefully answered all the questions.
Yeah, if no one else has any questions, our other presenter, Ashley, I believe they would like to share their own slides, but they can begin to present whenever they feel ready.
Okay, are you guys able to see my screen?
Yeah, it looks good to me.
So my name is Ashley Lincoln, and I help oversee our medication-assisted treatment clinic here at Cherokee Nation in Tahlequah, Oklahoma. A little bit of context. We serve around 500 patients. We have 3 providers, and we are now in 3 of our outlying clinics in our community. So I am the project director for our Tribal Opioid Response Grant. And today we're going to be talking about vicarious trauma, compassion fatigue, self-care. Our clinic we're large but small, if that makes sense. A lot of our patients we see multiple times a week. We have 3 providers housed here. We have clinicians embedded in our clinic and a family care manager. So we're all pretty close-knit. So these are some of the things that I heard around the clinic. Do any of these sound familiar to you guys? If I don't do it, who will? If we can't see them in our clinic, where are they going to go? I can't stop thinking about so-and-so. I'm afraid they may overdose. And I dread coming to work. I have to be honest, I am guilty of saying some of these things too. To this week for us has been, we've had around 40 patients scheduled each day, which is a lot for us. In the last month, we had 26 new inductions, which is a big number for us as well. Fentanyl has made it to Oklahoma, and it is just wiping out our community. We're having patients come in, and they're coming in because they're saying, I'm scared. One of my friends died of a fentanyl overdose, or someone had to use Narcan on me. And that affects, that I can't imagine what they're going through, but also our providers and everyone in our clinic hearing those things, it affects us. So what about self-care? I'm going to be honest, when people talk to me about self-care, sometimes I roll my eyes. And I know, because when you think about self-care, it's preventative. It's a preventative approach to burnout. And when it's done as a prevention effort, super effective. But working in high trauma populations, a tribal population, and working with substance misuse, from our providers, I see them often neglecting their own self-care. They care so much about their patients, and it's a lot of times life or death. So they're putting their own care aside. So when we're talking about self-care in these instances, we're coming at it from a reactive approach. And I'll never forget one time I was going through it. I was going through it and I was super crispy burnout. And someone said, why don't you go home and take a nice hot bath? And I was like, what is a bath going to do for my burnout? Like that's going to give me what, 30 minutes, an hour of like relaxation. But then when I'm done, I'm back where I started. And so to me, it kind of felt like a callous approach to my burnout for someone to suggest that to me. So I love this quote: self-care is not about self-indulgence, it's about self-preservation. So one of the things that we do these are some of the strategies that we use in our clinic. A big thing that we had to do was shift organizational culture. So one of the big things we do is we have shared decision making. And of course, there are instances where that's not possible. But we want the whole team's input. Anytime I have a new idea or something that I want to implement, I always take it to the team. What do you guys think about this? I do have to say, all of our providers took lunch from noon to 1. That was great. Well, what was happening is we were having some walk-ins come in during that time, or there'd be a crisis and we didn't have anyone in the clinic. So I was like, guys, we're going to stagger lunches. Okay. This is a great idea. We're going to be able to see, there's not going to be any gaps in services. We're going to see everyone that comes in. And I made that decision, and I made that decision on my own. And at the time I was like, this is a great decision. It was not. I didn't get the input of my team. I didn't get the input of the providers that I work with. And we staggered lunches. And you know what happens? Anytime we have a lunch and learn or an opportunity for a training, it's near impossible to schedule because everyone has staggered lunches. And so I went back to the team and I was like, listen, guys, I made a big mistake. I thought I knew what was best for our team, and I made a decision, and I didn't consult you guys, and that was pretty crappy on my part. And I apologize. And they were like, oh, wow. Like, and I said, we can move back to lunch from 12 to 1. We can work out those schedules. And I'm sorry that I didn't get your input. Because I know for me, when I've had someone come that's made a decision that's directly impacted my work, and they didn't consult me and it impacted me in a negative way, for them to come and say, man, I made a mistake, I didn't talk to you, it meant a lot. And transparency, like I said, I try to be super transparent. Anytime we're making decisions, we work in a large tribal health system at Cherokee Nation. So being able to, like, policies, procedures, and implement change, understandably, it has to go through a couple different channels. And it's not known for its speediness, so to speak. So for instance, we wanted to be able to do labs in our clinic. We have patients who have previous IV drug use, and getting their blood drawn can be a traumatic experience. We're the only outpatient clinic in the hospital. And so the lab here, they're dealing with crisis. They're working with urgent care, ER, ICU. And so when our patients would go down there, sometimes they weren't always met with patience. So we talked about it. The team was like, man, we wish we could do it in clinic, because then we could take the time we needed and we could make it a better experience. That process took a long time. And so I continually gave them updates. We meet every day at 8 o'clock. The whole team gets on Zoom. We used to meet in person, but everybody gets on Zoom, and we talk about how many patients are coming in today. Is there anyone we need to staff? We have 2 behavioral health clinicians embedded in our clinic. So we say, does anyone need a behavioral health contact, or do they need to see a clinician? Or, it's a time to say, so-and-so, they really seem to be in crisis. Maybe we need to have a treatment team meeting with them. And what we do with a treatment team meeting is every single person in our clinic that comes in contact with that patient, we meet in the conference room and we say, hey, we are here for you. Our program doesn't exist without you, and we're here to serve you. And right now you really seem to be struggling. What can we do to change this experience? Or maybe we're not a good fit for you. Maybe there's another clinic or another resource that we can help you with, because we do have requirements, and our whole team is a part of that, even the front desk staff. And the patient gets to choose who they want in there too. They may say, I want my sister, she's a great support, and I want Miss Cindy at the front desk. She's so kind to me every time I come in. I want her in there too. And we support that. And so we take a team approach to everything. I make the team do cheesy activities. Cheese is my favorite. I don't know if it's everybody else's, and sometimes it's forced participation, but so like, for example, I had everyone send me kind things. They had to send me 3 statements about a person. So the person on our team, everyone send me 3 statements about them, and why you appreciate them as a coworker. And then what I did is I put them all together and I created a word cloud with their name in the middle. And it was something so, it didn't seem like a lot, and it was so cheesy. But when I go to everyone's office, they have those word bubbles hung up in their office, and it meant a lot to them. And they were like, does the team really think that of me? They think that I'm really dependable, and they can tell that I really care about patients. And I was like, yeah, everyone sent those to me, and I just put them together to present to you guys. Sometimes we do a gratitude exercise or a mindfulness exercise on our huddles. And so another big thing that we do is creating that psychological safety among the team. So when we have a huddle or when a decision is made, it's important that the team feel comfortable enough to be able to disagree with it. So me making the decision about moving lunches, I didn't think about it. Listen, I go to lunch at 11 every day, and my body is set to that. Like, I go 0 to hangry, like 11:05, I'm done. And so to move someone's lunch is a big deal. If someone moved my lunch, it would be a big deal. And I didn't think about that. And I'm so thankful that the team was like, we know you made this decision, but it doesn't work for us. And I had to be able to hear that, and I had to be able to eat my words on that and to say, I'm sorry. But if they wouldn't have had that space to say, you made this decision and it's not the best for our team, how would that have played out? So it's really important to establish that sense of team, that they have that safety, that the rest of their team, that they can share, and that there's not going to be negative consequences. Sometimes we staff a patient and we don't agree on what, one person may not agree with the treatment that we decide, and we support that. We say, hey, can you tell us why? And sometimes we change it. So that's the thing. Our minds can always be changed. We want to have a shared space where everyone feels comfortable. Because one of the things we always say is, if you're the smartest person in the room, you need to find another room. So everyone here is an expert in their field, and everyone here brings something different to the table. And we want to foster that and encourage it. So another strategy that we do is following up after a traumatic experience. We had an overdose in our clinic. And like I said, we have some patients that we see. So we have some patients who are daily dosed. So we see them 5 days a week. So it's very much a sense of like, we know everyone on a first name basis. We feel very much like they're our family. And we had someone, and they were really struggling in their recovery. And we were really trying to support them and getting them into, we were getting them into rehab. And so they were going to come into our clinic to leave for rehab. And the day of, we received a voicemail at the front desk, and it was one of our patients, and it sounded like they were overdosing on the phone. So our whole team listened to the voicemail because we were trying to figure out who it was, because, we need to make sure they're safe. And I always say our front desk, man, they could be private investigators, because our front desk staff was like, I hear a baby, so-and-so has a baby. And we were able to figure out what patient it was. And it was the one that was going to rehab later in the day. Well, when they came in, we had a transport for them, and they said, hey, I need to use the restroom before I leave. And they used the restroom on the other side of the hospital. Well, when they went to use the restroom, they didn't come out, and they were in there for an extended period of time. And so someone went in there to check on them, and it turned out that they had used, and they were experiencing an overdose. So our team, they called a rapid response over our hospital loudspeaker, and just immediately we knew it was one of our patients. Our whole team of providers ran down there, and they had to use Narcan and to save this individual. And of course, that's the name of the game. Like we work in a hospital, we experience medical emergencies, but there was a different tone among the team after that happened. And being able to say, whoa, you guys went through it yesterday. Like, are you guys okay? Do you need to take the afternoon off? Like, that was a pretty heavy experience. So Cherokee Nation actually has a crisis response team. And so we were able to get our crisis response team. I organized for them to debrief with our team of providers. And we have clinicians on staff, but our clinicians experienced it too. And so we wanted to make sure that we were supporting them. So we brought them in to debrief with the team. And then we also got with hospital administration, because believe it or not, this is the first instance of that happening. And we were like, what can we do in the future to make sure that this doesn't happen again? Because we have a lot of single stall bathrooms. And what can we do? So administration was involved in how can we prevent this from happening again? And another thing that we're doing is we have found a contractor, a clinician here in Oklahoma out of the Panhandle, and she specializes in provider burnout. I'm working on getting a contract with her. So what she will do is groups with our team. So weekly groups just to check in with them. And all this to say, the team doesn't come to me and say, man, I'm burnt out. I think sometimes that's what happens with burnout or vicarious trauma, is it sneaks up on you and you don't realize you're in it until you're in it. And so, talking about self-care being preventative, we want to make sure that we're doing everything we can to help them in wherever they are at. If they are on the road to experience burnout, or if they were, like I was when someone suggested I take a hot bath, a crispy critter. And I was like, that seems like the most insensitive thing to say to me. We want to make sure that we're supporting them. And like I said, with that psychological safety, making sure that they have that safe space to vent frustrations. And they know, I tell them, I have an open door policy. Sometimes they come in and, I had a provider come in this morning and she was like, I'm so mad. And I said, oh, let's hear it. And she just laid it all out. And I said, okay. I said, I can tell that was really bothering you. Did you just want to vent, or do you want to problem solve how we can address it? And she was like, I think I'm good now. I got it out and I'm okay. And I was like, okay. But sometimes, they say, I need to address it. This is an issue I'm not happy about. And I say, okay, let's problem solve how we're going to address it with the team. Cherokee Nation also does this amazing thing where they give us 2 hours of mental wellness leave a month. So it doesn't accrue, it doesn't go, it's not a leave that they take away. It's, you get 2 hours, and say you're having a rough day or something happens, and you can let your supervisor know and say, man, you can take it in a 1 hour increment. You can have a longer lunch, you can come in later, you can leave at 3 or at 4. And I've noticed that this has really been beneficial to providers. We have one provider that was like, I never have time to get my nails done. And that's something that makes me really happy. And now that I have this mental wellness leave, I know that I can use it and leave early. That I can leave early to get my nails done. And then another thing that we do is we share successes, small successes, big successes. We share them all. The population that we're working with and the work that we're doing, sometimes we have experiences where, we're working with a patient and they're doing so well. And then, they relapse. And sometimes our providers take that on. Man, they were doing so good. And of course, we're here to help them and encourage them, but it still affects us. And is there anything else we could have done differently? So the things we're currently working on, in addition to those strategies, is a respite room. I saw an article about one of the hospitals around the Tulsa area in Oklahoma, that they have a self-care room it's a respite room for providers. It has low light, it has a sound machine, it has comfy chairs, it has coloring books. It has a yoga mat and a bouncy ball you can sit on. And I was like, is this something you guys would be interested in? And they were like, oh my gosh, that would be amazing. And so that's one of the things we're working on, is being able to have a space for them where if, they see a patient and it's a rough patient, because not only are we doing MAT, our patients come in and they've saved up all of their illnesses because this is the only time they access medical care. So when they come in, it's not just, I need a refill. It's, I have a refill and I have an abscess, or I have, cellulitis and I'm needing this addressed. And so, we want to make sure that we're encouraging them to take time for themselves, even if it's, 10 minutes to go in there and just decompress. Self-care day, we try to do these twice a year. The last time we tried to do this, we had lunch provided and we got little bags with some self-care items, and we were going to do an event as a group. We were going to do one of those like escape rooms, but they were going to do it like via Zoom. And we were stoked about it. Well, wouldn't you know, on that day, we had a bunch of walk-ins and we had a bunch of patients come in crisis. So we didn't even get to do, like, the irony was not lost on me. We planned a self-care day, but just kidding, we can't do it because we have to serve patients. And so being able to talk to the team and, I just asked them, what can we do to make you feel appreciated? Because I don't want them to, if you're already burned out, I don't want to give you a fancy notebook and a pen and you'd be like, wow, thanks, I'm not burnt out anymore. It's a nice gesture, but it doesn't eliminate the burnout. And so I said, I can't take task away from you. And I know we're short staffed and everyone's working really hard, but what could we do as a group that would make you feel appreciated? And they gave me some really good ideas. And at first, I think 2 of them were like, nobody's ever asked me that. I don't know how to respond. And so some of the things that they gave me, which are like, they said, I wrote them down. One of them was like, our offices are so cold. If I had a blanket on my chair, that would really make me feel appreciated. And I'm like, well, that's something so small. We can make that happen. It's nice to have a lunch catered in every now and then. Or, the one they said is, we really like the fancy Sharpie pens. And so, I thought that they would ask for these big grand things, but they were like, no, if we could get some Sharpie pens and a blanket and lunch, like that would make us feel really appreciated. And then, just them being asked for their opinion on that meant a lot as well. And then, like I said, we are currently in the process of contracting with a provider that is specific to burnout. And we are trying to move forward with doing an event for self-care 2 times a year. And then using these other strategies, these preventative strategies, every day throughout the year. So speaking of cheesy things, this is our team. And this was our Halloween costume, and we won a pizza party for it. And let me tell you, it was like, you would have thought we were in grade school and someone willed the TV in because you knew it was going to be a good day. Like when they said we won a pizza party, it was like we won $1 million. Not everyone in this picture wanted to participate in a group costume as well. And we were like, listen, we got a pizza party at stake. Can you participate? And everyone did. And the team came together. So we're Shark Week. And afterwards, everyone was like, that was so much fun. And our patients loved it. They thought it was hilarious. And then, of course, we had to explain it to everyone because it really didn't work as a costume unless we were really, standing together as a group. So it was fun to explain that. And so those are some of the things that we do. If you guys have any questions, that's my presentation. And here is my contact information. And I'm more than happy to answer any questions you guys may have. Thank you.
So once again, if anyone has any questions, you can feel free to drop them in the chat or unmute yourself and you can ask the question as well.
Oh, thank you. Yeah, like I said, when I asked them, I really thought they were going to be like a massage and all of these things, and then I was like, I was afraid I wasn't going to be able to accommodate that ask, but they, yes, were like, which I don't know if you guys use Sharpie pens, they are very superior, and so I was like, yeah, we could make that happen, and our one of the things that I think COVID took away from us was being able to get together as a group and share a meal, and not realizing the impact that had on our team. Because, we had our morning meetings in person, and sometimes we bring donuts in, or we would have a lunch and meet in the conference room. And that, we weren't able to do that. And so all of their suggestions was like, even if we could have lunch and get on Zoom and eat together, that would be really nice. So, like I said, if I wouldn't have asked them or took the time to ask them, I wouldn't have known some of those simple things to implement. Yes, I will put my contact information in the chat for you guys.
And I think a few people asked if we would be sharing the slides, and yes, we will be emailing a copy of the PowerPoint slides out to everyone after the meeting.
And another thing that I didn't really get to hit on is we use the Walking in Balance curriculum. It's specific to Cherokee culture, and it was created by Abraham Bearpaw. And the values that are in Walking in Balance, we use them with our patients, but we also use them in our service delivery. And with ourselves. So some of those concepts are communication and self-care, balance, gratitude. And so making sure that we implement those into every day. And we talk about strategies about how we implement them into every day. I was walking out to lunch yesterday, and I saw one of our peer recovery support specialists, and I said, "Hey, how are you? Are you going to lunch?" And he said, "Yes." And I said, we just had a Wellbriety event. And I said, "How did the Wellbriety event go?" And he said, "It went amazing, but how are you?" And I said, "I'm great." And he said, "What's been the greatest thing that's happened to you this week?" And speaking of my own self-care, I was like, what kind of question is that? And I really had to sit there and think. And he made me feel like the most important person in the world, and like he truly wanted to hear what I had to say. He asked me something very specific. What was the greatest part of your week? And so I thought of something, and I told him, which it was, I said, I went to lunch. It's always around food. I was like, I went to lunch and I got a salad because I'm trying to eat healthier. And I was totally prepared that this salad was going to be awful. I said, but it wasn't. And it was a great experience. And I was like, this tastes so good, and it's nourishment for my body. And he said, "Awesome. What are you doing for self-care?" And I was like, "Listen, I'm feeling attacked." And so, I said, "Oh, well, I'm trying to move my body and walk and things." But, just something simple like that, asking someone, "How are you doing?" But not just how are you doing, what has happened this week that's been really amazing for you? And so I've been trying to implement that because, like I said, it stayed with me all day. It really fed my spirit, and it made me, like I said, I feel like the most important person in the world. And so that's something we try to share with my team as well when we have conversations.
Well, it looks like there's no more questions in the chat or being asked. I know that I believe this webinar was supposed to go to 2:30. So does anyone else have any questions they'd like to ask or objections to adjourning early if everything has been spoken about, asked, or talked about that everyone's been wanting. All right, it seems to me like everyone's questions have been asked and answered. As we said already, there's a GIPRA link in the chat that takes you to a survey. We really appreciate if you fill that out. It gives us feedback that we incorporate into changing future things or anything that other people would like to see. And thank you all for being here. And a post-event email will be sent out where you can request certificates of attendance. That should be sent out shortly. And we will post the recording and the slides to our webpage, and the recording will be on our YouTube channel. And if that's all for everyone, thank you all for attending and have a great rest of your day.